This conference will now be recorded.
Just a second. Better now? Hello, is it better now? Can
Yes,
somebody
ma'am, it's
answer?
better. It's better now.
So today we will discuss regarding the peripartum hyponatremia. This is a little boring topic, especially more into the physiology. Okay, but since it is there in the recent talk, it is important. Maybe we can get few questions in the part two exam. So hyponatremia in pregnant women is an under-recognized complication of the peripartum feeding. So when you go through your previous practice or your residency, I think very rarely we have come across such a case. I've never encountered a case of hyponatremia. So
Giya, sorry to interrupt you. Your
hello.
voice is coming from far away. Like that is the problem, and that is why it is we cannot understand some words in between. Otherwise,
Okay,
you are audible, yeah, but it is
sure.
difficult to understand.
Yeah, just a minute.
Let me tell you in the meantime, guys, that Dr. Giya is not well. Even then, she is taking this session for all of you. So I think hats off to the dedication and seriously, all of us, like, we keep on putting all our hard work every time into our patients, into our studies. So really hats off to everyone here.
Is it audible now?
No, it's still not that clear.
Audible now?
No, you're audible. That's not the problem. The problem is it is difficult to understand words. So we are able to hear some part of it, and afterwards we lose connection. Like,
So, but this is an important thing we should be able to recognize in a peripartum patient. So, because the pregnant women are predisposed to complications because of the physiological changes in water.
Ma'am, we are unable to hear actually. There is too much background noise.
Background, one second, just hold on.
We will wait for 2 minutes. Dr. Giya, she's trying to fix the problem. We'll wait for another 2 minutes. But in the meantime, you can just go through the slide. And yes, in the free group, the
Hello?
talk is also in the free group. Yes.
Hello?
Yeah, now this is very clear now.
Oh, okay, okay. Maybe something wrong with my headphone. Okay, thank you. So hyponatremia is from this topic is from the recent talk, and we know that from my personal experience, I have never encountered such a clinical situation, but maybe rarely this is one of the cause of peripartum morbidity and mortality in pregnant women. That's why they have given importance to this topic. So we can expect few MCQs from this talk, especially in the part 2 exam. So this is a little boring topic because moreover physiology is covered here, but few important points we need to understand. So this hyponatremia in pregnant women is an under-recognized complication of the peripartum period. Some women are especially prone to this hyponatremia because normally we know that there are some physiological changes which happens for the water and electrolyte in pregnancy and the peripartum period. So usually when hyponatremia happens, this is mild and is well tolerated. But if the level of sodium is less than 125 millimole, it can cause a high risk for the baby and the mother, newborn baby. So this 125 millimole is very important. For part 2 exam, we should fix in our mind that normal sodium, we know that like it is between 135 to 145. But if it is coming less than 125, this is significant. The most important thing is like we have to early recognize these symptoms and signs in the in peripartum hyponatremia. This is the most important thing in the management. So I just want to briefly talk regarding the renal physiology happens in the pregnancy. We know that the kidneys usually increase in size. The urinary collecting system also dilates, and there will be a mild physiological hydronephrosis. And the renal changes that happens in the pregnancy is the renal blood flow will increase. As a result, the glomerular filtration rate will increase. This result in the kidneys are in a hyperfiltration state. So usually the creatinine clearance increase with a subsequent decline in the serum creatinine level. We know that the normal creatinine level is 0.8 to 1.2. But in pregnancy, we considered like normally the amount of creatinine will be less in pregnancy. So from 0.6 to 0.8 will be considered as normal. Okay, so a mild we will consider a high amount, high creatinine if the level is above 1 itself, we consider that it is high. The physiology behind this is the creatinine clearance increase, which result in subsequent decline in the serum creatinine level. So the point you have to fix in your mind is in pregnancy, the amount of creatinine in the serum will be less comparing with the non-pregnant state. Also, the nephron will filtrate the sodium and potassium. The filtration rate will be increased, but their excretion remains unchanged because of the enhanced tubular reabsorption. So the nephrons, the glomerulus will filtrate more sodium and potassium, but gradually when it reaches the tubes, it will get reabsorbed. Also, there is mild proteinuria and glucosuria in pregnancy, and serum bicarbonate levels will decline. Okay. So normally pregnancy is a state of positive water balance. There's an average accumulation of 6.5 to 8 liters of fluid by the third trimester as a result of pregnancy-induced hypervolemia and water excess. Also, the plasma osmolality decreases by 10 milliosmol per kg and falls to 280 milliosmol per kg from approximately 10 weeks of gestation until 1 to 2 weeks of postpartum. I mean, when you read all these things, you will feel like these are a little boring, but each talk article has some some true or false questions in the back of the talk. So there are questions from each of these sentences, like how much the plasma osmolality will decrease. It will normal plasma osmolality is from 275 to 290. So usually it decreases by 10 millimosmol and it becomes 280 from approximately 10 weeks till 1 to 2 weeks postpartum. So this is an important sentence. Then there is associated with a decrease in the osmotic level for thirst, and non-osmotic ADH secretion is also decreased. So ADH causes antidiuresis. It will hold more water, so it naturally causes a hypervolemia. The function of renin, angiotensin and aldosterone system, which regulate the fluid balance and blood pressure, is enhanced to accommodate extra needs of pregnancy. So because of this upregulated renin, angiotensin, aldosterone system, the volume expansion and the natural vasodilatation in pregnancy, all these things will lead to physiological hypervolemia. That leads to decrease in serum sodium level. So naturally there is a slight decrease in the serum sodium levels to 130 to 145 millimoles per liter compared to non-pregnant state of 135 to 145. So this value, normally there is a hyponatremia because of all these reasons. So there are some risk factors which can lead to peripartum hyponatremia. So when we are managing a patient with these risk factors, we have to be more conscious, and we have to prevent hyponatremia in these patients, especially a patient with a lower baseline sodium in pregnancy. Actually, routinely we are not sending the electrolytes for a laboring low risk patient. Maybe for a hypertensive or preeclamptic patient, we'll send the sodium. So we never used to bother to look into that value, but always when patient is on oxytocin or she is having any of this risk factor, we should make a habit of looking into that baseline sodium level. If the baseline sodium level is already low, there is a chance that she can develop hyponatremia in pregnancy. Then if the patient, the labor related nausea, vomiting and stress or pain, starvation can increase the ADH secretion. So when ADH increase, more chance for hypervolemia, and there can be a hyponatremia. Then if physiological oliguria and antidiuresis, normally because of this oxytocin is normally released during in labor, and this has a mild action similar to the ADH that can lead to a physiological oliguria and antidiuresis. This can also lead to hyponatremia. Then prolonged labor and oxytocin augmentation protocol and excessive use of IV fluid, and if the patient is having a positive balance of more than 1500 ml, or patient is on a combined spinal epidural analgesia, and dextrose infusion, all these things can lead to peripartum hyponatremia. So this slide is important. We have to by heart this slide. I'll come into detail regarding each risk factor. So during painful contraction, stress hormones are released and patient can have this nausea, vomiting, dehydration, and this stimulates the secretion of ADH. Especially in UK, in the latent labor, they are not admitting the patient. They will send the patient back home, and they will ask the patient to come back in the active labor, especially the low risk women. So we are not able to assess the amount of fluid or intake in those patients. Okay, so all this painful contraction and this excess nausea, vomiting and all will stimulate the secretion of ADH. Consequently, greater amount of water is retained and urine excretion become impaired, because we are not routinely monitoring the urine output and amount of intake in this low risk patients. Consequently, greater amount of water is retained and urine excretion becomes impaired, and oliguria occurs physiologically in labor, followed by polyuria in the recovery phase. Then regarding oxytocin, there is natural oxytocin and the oxytocin which we like exogenous oxytocin we use to augment or induce labor. The natural endogenous oxytocin is a hormone which is secreted by the hypothalamus and it is stored in the posterior pituitary. So it is a neuropeptide that differs by 2 amino acids from ADH. These structural similarity between ADH and oxytocin leads to a cross reactivity of binding in the receptor of the other hormone. So the synthesis of oxytocin receptor in the myometrium is increased dramatically before the onset of labor, along with its responsiveness to oxytocin. So normally we know before delivery, the receptors in the myometrium, the oxytocin receptors in the myometrium will be increased, and the myometrium towards term, the myometrium will be very much responsive to this oxytocin. The receptors are very much responsive to the oxytocin. So oxytocin mediates action by reacting with the vasopressin ADH2 receptor on the collecting duct of the kidney. So this is little important. It acts mainly on the vasopressin ADH2 receptor in the collecting duct of the kidney. Other than the paturation, the myometrial contraction, the other action of this endogenous oxytocin is it will cross-react with the vasopressin receptor. So hence, apart from its uterotonic property, oxytocin also has a mild antidiuretic effect. Then regarding the exogenous oxytocin, the exogenous oxytocin act in the same way as endogenous oxytocin. Therefore, oxytocin infusion can potentially exacerbate hyponatremia. The hypotonic dextrose solutions, we know that we have isotonic solutions, hypertonic solution, and then isotonic, hypertonic, and hypotonic. So isotonic is our sodium chloride, 0.9% NaCl. Hypotonic dextrose is maybe the sodium content is less there, 0.45%. So when you use this hypotonic dextrose solution, and also the high infusion rate protocol of the oxytocin, usually we dilute oxytocin in 10 units, international unit, and then we will start with 1 to 2 milli-unit per minute. So in high infusion, 30 international unit is mixed in saline, and we usually infuse. So high infusion protocols have caused hyponatremia, especially when you use this hypertonic dextrose and high infusion protocols. Hence, the synthesized oxytocin is dilute in isotonic or normal saline solution. So it's very important. Always we have to give oxytocin in normal saline, that isotonic solution, 0.9% NaCl. So even with high dose protocol in isotonic fluid, the incidence of hyponatremia is, suppose if you are giving this high dose protocol in isotonic fluid, the risk of hyponatremia is low. But if you are mixing this oxytocin in hypotonic fluids, the incidence is more. The duration and quantity of the fluid rather than the actual oxytocin concentration are the significant in hyponatremic aggravation. So they are telling basically that more than oxytocin, if you are giving fluids for a long duration and we are giving a hypotonic fluid, there is more risk for hyponatremia. Then prolonged, especially augmented labor, antidiuresis associated with the oxytocin become greater. Normally what happens when we give oxytocin for long duration, these myometrium become less sensitive, and there will be like ineffective myometrial contraction. But the effect of oxytocin in the like ADH will be persisting. The effect on the myometrium will not be there, and the effect, so this leads to too much water retention and hyponatremia. Then other risk factors, we know that if suppose a patient is starving for a long time, this leads to ketosis. When we see the ketones are positive, what we will do? Automatically we give more fluid. So this leads to dilutional hyponatremia. So further fluid intake is advised with IV. So the risk of dilutional hyponatremia increases with increasing fluid administration, with the risk being 1% in less than 1 liter versus 26% in those who receive more than 2.5 liters. If you give more fluid for ketonuria during labor, then the chance for hyponatremia is more. Also, if the positive field, water balance is more than 1500 ml, there is a risk for water intoxication. Then we also there is a traditional procedure that if suppose we are seeing some CTG abnormalities, we usually give a fluid bolus. But now recently they have challenged this theory because of the lack of evidence and the risk of maternal and neonatal hyponatremia. Then also this neuraxial or epidural analgesia, this causes maternal hypotension because it blocks the sympathetic nervous system, which results in vasodilatation and subsequent functional hypovolemia. So when you give the patient epidural, then she will go into hypotension. Then what you will do? You will give more fluids. This ultimately results in hyponatremia. And also there's a risk for fluid overload. So, so we have to monitor the sodium in the following cases, like especially women on oxytocin infusion. especially induction, augmentation, or management of postpartum hemorrhage. And if the positive fluid balance of more than 1500, and women is on dextrose and a variable insulin regime. If she is type 1 or type 2 diabetic, we have to give insulin, the dextrose drip. Such patients also are more prone to hyponatremia. Also, if in the start of the labor itself, if the serum sodium is less than 130 millimole, they are also at risk for peripartum hyponatremia. So this is an important point. All these patients, we have to be more vigilant. Then usually most of the women can tolerate the hyponatremia.
Here is your reminder. Try wash and
So most of the women can tolerate the hyponatremia without any clinical signs. Early signs can easily be mistaken for a normal presentation secondary to labor, stress, dehydration, and exhaustion. Symptoms usually arise when the sodium levels are below 125 because of the reduced plasma osmolarity, which leads to severe and rapidly progressive neurological sequence. So this is very important point, like serum sodium levels less than 125 millimoles, and the symptoms will be mostly neurological. And the clinical presentation is non-specific, and it is in the early stage, it is reversible with the prompt management. Also, irreversible neurological disability and death can rarely happen. And early signs include headache, anorexia, nausea, and lethargy and apathy. And moderate to severe hyponatremia can present with disorientation, agitation, seizures, depressed reflexes, coma, respiratory arrest, and non-cardiogenic pulmonary edema. So mainly the symptoms are neurological symptoms. There is a slide, there is a chart in the TOG regarding the differential diagnosis of this hyponatremia. So that includes this hyperglycemia can lead to pseudo hyponatremia. I don't know whether this is that important, but just you can go through before the exam. So this hyperglycemia can lead to pseudo hyponatremia. Here the plasma osmolarity will be normal. And other causes of hyponatremia where the plasma osmolarity is low is the thiazide diuretic, mineralocorticoid insufficiency, sodium wasting nephropathy, GI loss, burn, pancreatitis, trauma, and peritonitis. All these conditions, we know that there will be the blood volume is reduced. When there is burns or excessive GI loss, the blood volume will be less, and the plasma osmolarity will be low. There is loss of sodium. So when burn happens, there will be sodium loss. So volume will reduce, and the osmolarity also reduce. But in hyperglycemia, it is normal. And the other syndromes like SIADH, syndrome of inappropriate ADH secretion, hypothyroidism, adrenal insufficiency. Here the osmolarity is low, but the blood volume is normal. And in other like cardiac failure, liver failure, nephrotic syndrome, the osmolarity is low and the blood volume is increased. In cardiac failure and liver failure, there will be excess fluid, so the blood volume will be increased. So this, I don't know whether it is too important, but maybe you can just go through. Then there are other pregnancy-specific conditions causing hyponatremia, like especially PET-induced severe hyponatremia usually present antenatally with deranged levels. And this PET can, preeclampsia can cause nephrotic syndrome that can lead to hypervolemia and without a pre-existing underlying renal disease. So this preeclampsia associated syndrome of SIADH has proposed as a potential etiological factor in this non-dilutional hyponatremia. So if suppose a patient can present in the post peripartum period with seizure, it can be due to a PET induced nephrotic syndrome leads to hyponatremia. It can be because of some hyponatremia induced seizure, or the PET itself can cause a seizure. So it is reasonable to administer magnesium sulfate for any under-recognized seizure in pregnancy and postnatal where the diagnosis is not clear at the first presentation. So they are just wanted to tell us that the seizure is not because of PET, it can be cause of, it is because of hyponatremia also. And in Sheehan syndrome, there is hypopituitarism. 50% of the cases will present with postpartum hyponatremia secondary to adrenal deficiency. And actually, if a mother is having a hyponatremia, there is no studies have described the CTG changes consistent with the pressure of with the presence of maternal hyponatremia. But some rare case series are there, like noted some pathological and non-reassuring CTG patterns in labor preceding to hyponatremia-induced neonatal seizures. So why this hyponatremia in mother is more important? Because it can lead to neonatal seizures and neonatal neurological symptoms, not only the mother. So this chart is important. So monitor sodium in labor, how to manage a peripartum hyponatremia, especially in the antenatal women. So we have to monitor the sodium in labor when a patient is on oxytocin infusion for induction of labor augmentation, or we have given oxytocin for PPH. Then or a patient is on dextrose and variable insulin regimen, and positive fluid balance of more than 1500, and sodium is less than 130. If sodium more than 130, no need for aggressive monitoring. If it is less than 130, we need to monitor the patient. So if it is more than 130 and risk factors are there, we will do electrolyte, urine electrolyte, or we can do ABG or arterial blood gas analysis or venous blood gas analysis. And if it is more than 130 for these high risk patients, no fluid restriction, and we have to repeat the sodium after 8 hours, especially if her fluid balance is more than positive fluid balance of 1500. So more than 130, after 8 hours, we need to monitor if still the risk factors are present. Then suppose between 125 to 130, the fluid should be restricted to 80 ml per hour, and we have to repeat sodium in 4 hours and inform a senior obstetric team. The consultant in obstetrician should be informed, and also they inform the neonatal team. This is something new. If sodium is less, we never used to inform the neonatal team, but here they says that the baby can have complications, so we have to alert the NICU team, and also the consultant should be informed. And if the sodium is less than 125 with or without symptoms, the fluid restriction should be 30 ml per hour, and we have to repeat 2 hours. So more than 130, 8 hours, 125 to 130, it is 4 hours, and the critical level of sodium less than 125, we have to repeat every 2 hours. And here we have to stop the oxytocin, and we have to involve the multidisciplinary team, including the obstetrician, anesthetist, neonatal, and renal and medical team. So after stopping the oxytocin and restricting the fluid, there is still symptoms and worsening of hyponatremia, then we have to involve the critical care team, and we have to give 2.7% saline in 200 ml in 30 minutes. We have to treat the patient with saline. Also, if there is signs of fluid overload, we can give furosemide 20 milligram IV. I think this is an important slide. Okay, so this value is important. Here the fluid restriction is 30 ml, and we have to monitor every 2 hours. And after restricting the fluid and stopping the oxytocin, if still the symptoms are persisting, then we have to treat the patient with 2.7% saline in 200 ml. After delivery, we will again check the sodium, and if it is more than 130, no further action is required unless clinically indicated. And if between 125 to 130, no fluid restriction unless clinically indicated, and repeat the sodium after 8 hours and discuss with the obstetrician and anesthesia team. Still, the sodium level after delivery is in a critical state. We have to, restrict the fluid for 30 ml per hour, and repeat sodium if risk factors still present in 4 hours. And if postpartum for PPH, we are giving oxytocin, we have to stop it, and we need to involve the other teams. So regarding the neonatal outcomes, the maternal baseline serum sodium is lower, and water concentration rapidly equilibrates across the placenta. So suppose if mother is having low sodium and hypervolemia. Through this can equilibrate through the placenta, and the effect can be there in the fetus also. So normally at the time of labor, fetal ADH secretion increases profoundly before and during labor as a response to hypoxic stress because of contraction and direct cranial pressure during contraction. So there will be increase in ADH secretion in the fetus. Hence, a neonate who have a limited renal capacity can also become severely hyponatremic in the presence of maternal fluid on. So when there is maternal fluid overload and hyponatremia, they can reflect to the fetus. Okay, and when there is an hypoxic environment associated with the fetal distress in labor, the adjunctive effect of hyponatremia can deteriorate the overall cerebral edema, and this can lead to neonatal seizures requiring cooling therapy, like what we are seeing in the hypoxic ischemic encephalopathy. So the fetal effect, why we are so much worried about this hyponatremia, because the fetus at risk of hypoxia can develop a cerebral edema and can develop a neonatal seizure, which needs a cooling therapy similar to the hypoxic ischemic encephalopathy. So when the mother is at a critical level of hyponatremia, the pediatrician should be informed, and newborns may present with symptom usually when the sodium is less than 125, similar to the mother. So this value of 125 millimole is important. The neonatal symptoms can be early or late. Especially early symptoms at birth is breathing difficulty, low UPCAR requiring NICU admission. And in the early neonatal period, the baby can have irritability, hypertonia, lethargy, feeding difficulties, weight loss, apneic episodes, seizures, jaundice, and coma. So we have to think that the result of hyponatremia is neurological symptoms. So peripartum hyponatremia requires early detection and management, ensure an excellent prognosis for the affected mother and babies. Prolonged labor and excessive water consumption or excessive IV fluid administration and prolonged oxytocin induction or augmentation. In all these patients, we need a clinical vigilance to check and treat the sodium balances of this patient. And especially there is a positive fluid balance, we have to think of risk for hyponatremia. And the prevention is the most important thing for the well-being of the women in the postpartum period. And fluid chart along with the partogram should be an integral part of laboring mother, high risk or low risk labor management. Okay, so so now I will give few questions. Those who are listening to me should try to answer. Okay, who will answer this first question?
True.
Okay, so regarding renal physiology in pregnancy, the creatinine clearance increases leading to decreased serum creatinine levels. The answer is true.
True.
Okay, what about the next question? The plasma osmolality increases by 10 milliosmol per kg.
False.
Yeah, it's false. So it decreases by 10 milliosmol. Then the serum sodium levels drop from 135 to 145 to 130 to 145. This is
True.
Okay, and the bicarbonate level remains unchanged.
False.
Yeah,
It
it
decreases.
decreases. And this nephron excretion rate of potassium increases. True or false?
False.
Actually, the nephron excretion rate of nephrons will excrete too much potassium and sodium, but the tubes will reabsorb all these things. So I think it should be true. When you go through the lines, they have mentioned that nephrons will excrete more, but there is an enhanced tubular reabsorption. So it should be true. Okay. And in pregnancy, the antidiuretic hormone secretion is increased during labor.
True.
True.
False.
So naturally, when there is labor, the ADH secretion is increased, which leads to a mild water retention. The action of ADH and oxytocin on fluid retention in labor works as antagonist. Is it antagonist or agonist?
False.
Yeah,
Agonist.
Both have the same function. Yeah. Then risk factors for peripartum hyponatremia include prolonged labor,
True.
true,
True.
oxytocin use, true, and fluid deficit more than 1.5 liter. And with regard to neonate, there are at risk of hyponatremia because of metal sodium concentration rapidly equilibrate across the placenta. This is true.
True.
Yeah. And seizures are the recognized consequence of maternal hyponatremia. That is also true. Then regarding signs and symptoms of hyponatremia related to CNS system dysfunction. True.
True.
Yeah. Are reversible with prompt management.
True.
True. True. And regarding the management of peripartum hyponatremia, serum sodium levels needs to be repeated every 4 hours if found to be over 130 millimoles per liter. See, they are asking small questions from that chart. So if it is more than 130, you have to monitor every 8 hourly.
8 hourly.
Yeah, between 125 to 130, 4th hourly, and less than 125 every 2 hours. Okay. Then fluid restriction to 30 ml per hour is required if serum sodium levels are less than 125 millimoles per liter.
True.
Yeah, and for if the levels are between 125 to 130, the fluid restriction should be 80 ml per hour. Okay. And acute kidney injury is a recognized complication. This I feel it's false. I couldn't read any sentence which is stating like this, but moreover, it's a neurological symptoms than kidney injury. Okay. Sometimes a patient with hyponatremia and this acute kidney injury associated with hyponatremia, we need special involvement of CCU team for the management. But I don't think that hyponatremia will lead to a kidney injury. It has more neurological symptoms. Okay. I hope you understood something. You got some important take-home message from this session. I hope this is useful for you. Do you have any doubts? This is the most important slide. Okay. Yeah, so before you go to for the exam, you have to at least, I know it's when you have too many things to remember, it's really difficult to go through each and everything. But at least if you can make some notes from the section, or even you can take a screenshot and prepare in the Word file itself. The last moment you can revise and go. It's not easy to read the entire talk and go before the exam. So whatever I discuss, I mean, they have given few charts there. So whatever they have written there is mostly the important points are there in the charts. So just at least go through the charts and before the exam, so you will have an idea. Okay. And whenever you read a talk, try to go through the questions which are asked in the back of the talk, because recently they are asking more. They are not giving the answers of that talk questions. So recently we have seen a trend that they are asking more questions from the MCQs from the backside. Okay. So whenever you read the talk, please go the backside and read that MCQs also. So maybe the lines which are important, they are asking the questions. Okay. If you have any doubts, I can answer. I hope this session is useful for you. Okay. Thank you then.
Somehow I felt that it is so important to listen to all these online sessions, live sessions, because what happens is you finish the whole talk in some 40 minutes. Within 40 minutes, we finish the whole talk, we finish the question answers, and it is there in the heads for lifelong now, because it has been discussed so nicely. If you read the talk by yourself, it will not take less than 2 hours, and you retain very less from the talk if you read by yourself. So this is how you should be reading for part 2, for part 3, and this is how the study should be. So that is why it is very, very important to attend the live sessions to make the maximum use of the courses that you have put your money in, and it is really important to listen to your mentors. So this is what I again, like, this was reinforced in my mind also after listening to your session, Giya. And seriously, you are a very good teacher, I must say. And
Thank
thank
you
you
so
so
much.
much, even
I
if
don't know.
you were not well, and even then you took the session really, really incredible.
Because I took long time to prepare because it's extremely physiology that we are not remembering since we are not going through long time.
But
So
I don't think anybody will forget any of these slides that you have mentioned, because things were repeated every now and then, and you again reinforced everything by taking the question and answers. So I think everybody who has
because the
attended,
questions they are asking from each lines, so I think that is important. Now recently there is a trend like they're asking questions from the, I mean, from the CPD questions. So
yeah, but whoever session, they are really benefited, and those who couldn't join, seriously, this was a loss, because when you attend it live, it is going to make a different impact in your brain. That is for sure.
yeah, thank you, Preeti, for your nice words. Okay, so all the
Okay.
best, study well, and